Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 349 of our pharmacotherapy entitled Dosing of Drugs in Renal Failure. The next case reads, TNH, a 57-year-old, 85 kilograms man with chronic kidney disease secondary to poorly controlled hypertension, presents to the emergency department with a 24-hour history of fever, that is a body temperature of 39 degrees Celsius, altered mental status, nausea, and vomiting. On physical examination he is found to have nuchal rigidity and a positive Brudzinski sign. Laboratory analysis reveals the following: a WBC count of 22,000 per microliter with 89% neutrophils. A BUN of 45 mg per deciliter. Serum creatinine of 4.4 mg per deciliter. A lumbar puncture yields cerebrospinal fluid, CSF, with a WBC count of 2,000 per microliter, 90% polymorphonuclear neutrophils, a glucose concentration of 36 mg per deciliter, and a protein concentration of 280 mg per deciliter. Gram-positive diplococci are seen on CSF smear. A diagnosis of meningococcal meningitis is made, and potassium penicillin G is ordered. So my question to you is, what dose should be used? Meningococcal meningitis can be treated with 20 to 24 million units of IV penicillin G in patients with normal renal function. As with many beta-lactam antibiotics, penicillin is primarily excreted unchanged in the urine with little or no hepatic metabolism. Thus, the elimination half-life, which averages less than 1 hour in patients with normal kidney function, increases to 4 to 10 hours in patients with end-stage renal disease. Methods to modify the dose of penicillin in renal insufficiency have been developed by numerous investigators. The clearance of penicillin correlates closely with creatinine clearance according to the equation Cl penicillin is equal to 35.5 plus 3.35 times the creatinine clearance. This correlation is based on data from patients with varying degrees of renal impairment. An equation to estimate the total daily dose for patients with renal failure to achieve serum levels similar to those produced by high-dose penicillin, that is 20 to 24 million units per day, in patients with normal renal function has been developed for patients with an estimated creatinine clearance of less than 40 milliliters per minute. The dose for TNH should be given in equal divided doses at 6 or 8 hour intervals, can be calculated using the formula, dose of penicillin and megaunits per day is equal to 3.2 plus creatinine clearance divided by 7. Using the Cockcroft-Gault method, TNH's creatinine clearance is approximately 20 milliliters per minute. Therefore, his daily dose of penicillin should be 6 million units. A dose of 1 million units every 4 hours would be appropriate for TNH. Penicillin G is often given as the potassium salt, penicillin G potassium, which contains approximately 1.7 milliequivalents of potassium per 1 million units of penicillin. Accumulation of potassium due to renal impairment may lead to hyperkalemia. Penicillin G sodium is an alternative formulation that would be appropriate. As is true for many agents, these dosing recommendations are empiric and based on pharmacokinetic principles for patients in renal failure. These recommendations have not been subjected to carefully designed clinical trials that establish therapeutic efficacy. Therefore, other factors that can influence host response also should be considered when designing an individualized therapeutic regimen. These include the host's immune status, the presence of other medical conditions, microbial sensitivity patterns, and changes in pharmacokinetic disposition, e.g., concomitant liver disease, fluid overload, dehydration. My next question to you reads, the prescriber fails to consider TNH's renal dysfunction when he orders penicillin, and begins a dose of 4 million units every 4 hours. 4 days later, TNH is encephalopathic, that is, he is confused, disoriented, and difficult to arouse, with some twitching noted on the right side of his face. Are these toxic symptoms associated with high-dose penicillin? What predisposing factors may contribute to this neurotoxicity? TNH is experiencing signs of neurotoxicity that are consistent with elevated penicillin concentrations in the plasma and CSF. Penicillin usually produces few serious adverse effects. When large doses are used in patients with renal impairment, toxic symptoms such as those exhibited by TNH can result. Signs and symptoms of penicillin-induced CNS toxicity include myoclonus, complex or generalized seizure activity, and encephalopathy progressing to coma. Predisposing factors: TNH's renal dysfunction predisposes him to penicillin-induced neurotoxicity. In a review of 46 cases of penicillin-associated neurotoxicity, decreased renal function was present in 35 patients. Several possible explanations for this observation exist. Penicillin accumulates in patients with renal failure. The binding of acidic drugs, such as penicillin, to albumin is decreased, resulting in an increased fraction of free or active drug that can pass into the CSF. Alterations in the blood-brain barrier have been observed in uremic patients, which can lead to further increases in CSF drug levels. High plasma concentrations of penicillin per share may contribute to changes in the blood-brain barrier permeability of this drug. All these factors, together with the increased sensitivity of patients with renal failure to centrally acting agents, make CNS toxicity more likely. Previous neurotrauma, history of seizures, elderly age, and concurrent drugs that lower the seizure threshold can also contribute to neurotoxicity. As with penicillin, the carbapenem antibiotic combination, imipenem-C-Listatin, is associated with a higher incidence of seizures in patients with renal dysfunction. Other beta-lactam antibiotics such as ceftazidime, cefepime, and piperacillin, tazobactam have also been associated with seizures. The next case reads, MOH, a 44-year-old, 70 kg woman with acute non-lymphocytic leukemia, was admitted to the oncology ward for placement of a Hickman catheter for her chemotherapy. 7 days after treatment with cytarabine and daunorubicin, her temperature spiked to 39.4 degrees Celsius. Other physical findings consistent with sepsis included a blood pressure of 102 systolic, 68 diastolic, pulse rate of 112 beats per minute, and a respiratory rate of 27 breaths per minute. MOH is neutropenic with a WBC count of 1,400 per microliter, with 3% polymorphonuclear leukocytes, 70% lymphocytes, and 22% monocytes. Her platelet count is 16,000 per microliter. MOH also has renal dysfunction as reflected by an serum creatinine and BUN of 2.6 and 38 mg per deciliter, respectively. Empiric therapy for sepsis is started with tobramycin, piperacillin, tazobactam, and vancomycin. So my question to you reads, how should piperacillin, tazobactam be dosed in MOH? Piperacillin is an anti-pseudomonal penicillin that is often used with an aminoglycoside to treat serious infections caused by gram-negative organisms. Piperacillin is commonly given as a combination with tazobactam, a beta-lactamase inhibitor. In patients with normal renal function, piperacillin is primarily excreted unchanged by the kidney with a clearance of 2.6 ml per minute per kilogram, and a half-life of approximately 1 hour. Doses of piperacillin, tazobactam can be as high as 4.5 grams every 6 hours for the treatment of serious Pseudomonas species infections. In patients with end-stage renal disease, mean piperacillin clearance and half-life values are 0.7 ml per minute per kilogram and 3.3 hours, respectively. Although these parameters are significantly different, they are less than those expected for a drug primarily cleared by the kidneys, suggesting that some other compensatory mechanism for elimination must be present. Piperacillin is partially cleared by biliary excretion, a route of elimination that is increased in patients with renal failure. Therefore, aggressive dosage reductions in MOH are unnecessary. An appropriate dose of piperacillin, tazobactam for MOH would be 3.375 grams every 8 hours. Widely used drug references such as facts and comparisons can be used for dosing guidelines for drugs commonly used in patients with renal failure. In addition to the aforementioned regimen for MOH, vancomycin therapy is initiated at 500 mg every 24 hours to cover the possibility of an infection resistant to antistaphylococcal penicillins, such as nafcillin. Is this an appropriate dosing regimen for MOH? Vancomycin is a bactericidal antibiotic with excellent activity against most gram-positive organisms such as methicillin-resistant Staphylococcus aureus and Streptococcus species, including some isolates of Enterococcus species. It is used empirically in febrile neutropenic patients because the incidence of infection secondary to resistant organisms is much greater in this patient population. However, cases of vancomycin-resistant enterococci have emerged at rates as high as 50%, raising concern and reducing its empiric use. Vancomycin is poorly absorbed by the oral route and must be administered IV when used to treat systemic infections. As with many other antibiotics, vancomycin primarily is cleared by the kidneys. Significant toxicities have been associated with elevated serum concentrations, making careful dosing modification in renal failure necessary. As with the aminoglycosides, pharmacokinetic calculations can be used to individualize a dosing regimen to produce the desired peak and trough plasma levels. Unlike the aminoglycosides, the therapeutic range for vancomycin is less clear. Normally, Doses are designed to achieve peak levels of 25 to 40 mg per liter and trough levels of 10 to 15 mg per liter. The correlation between vancomycin toxicity, e.g., ototoxicity, and plasma levels is not well defined. Some clinicians have suggested, however, that plasma levels of 80 mg per liter or more may correlate with auditory dysfunction. Vancomycin has an elimination half-life of 3 to 9 hours in patients with normal renal function. This increases to 129 to 189 hours in patients with end-stage renal disease. Using pharmacokinetic principles and considering that the plasma clearance of vancomycin is approximately 60% to 70% of creatinine clearance and the volume of distribution averages 0.7 liter per kilogram, the estimated VD vanco and CL vanco can be calculated using the relevant equation. They amount to 19.8 milliliters per minute, rounded off to 1.2 liters per hour and 49 liters respectively after computation. Based on estimated values for CL vanco and VD vanco, the elimination rate constant can be calculated using the relevant equation, resulting in a KD equal to 0.024 per hour and a CP equal to 23 mg per liter. Because MOH's estimated peak concentration is less than 40 mg per liter and her trough falls within the range of 10 to 15 mg per liter, the starting dose of 500 mg every 24 hours is appropriate for MOH. Routine monitoring of plasma vancomycin concentrations in patients with normal renal function is controversial because the likelihood that toxicity will develop in this group is relatively low. However, in patients with renal failure, such as MOH, it is advisable to measure vancomycin levels several days after initiation of therapy to ensure that they are within an acceptable range. This is prudent if an extended course of therapy is anticipated. Vancomycin is usually infused over the course of 60 minutes. MOH's renal function begins to deteriorate to the point where she requires hemodialysis. So my question to you is, how should her regimen now be altered? Patients with end-stage renal disease may have measurable vancomycin levels for up to 3 weeks after a single dose despite conventional hemodialysis. This suggests that the ability of these patients to eliminate vancomycin is minimal and that little of the drug is removed by conventional hemodialysis. The elimination half-life for vancomycin in these individuals averages 5 to 7 days, which is consistent with a residual vancomycin clearance of 3 to 4 milliliters per minute. Only about 5% of vancomycin is metabolized hepatically in patients with normal renal function. Conventional hemodialysis removes about 7% of vancomycin during a typical 4-hour dialysis run. The elimination half-life on and off dialysis and plasma levels of the drug before and after hemodialysis do not differ significantly. The poor removal of vancomycin by conventional hemodialysis is attributable to its large molecular weight of 1,400. Patients receiving conventional hemodialysis are typically given a single, 1-gram dose every 7 to 10 days. Based on MOH's estimated volume of distribution of 49 liters, this dose will produce an initial peak plasma level of approximately 20 mg per liter. If vancomycin is administered weekly, steady-state peak and trough levels of 40 and 16 mg per liter, respectively, would be predicted. Vancomycin is removed to a greater extent by high-flux hemodialysis than by conventional hemodialysis. As a result, more frequent dosing is necessary to maintain therapeutic vancomycin concentrations. High-flux dialysis clearance of vancomycin using the Fresenius polysulfone dialyzer is 45 to 160 ml per minute and varies with membrane surface area. Up to 50% of a dose of vancomycin is removed in 4 hours by high-flux hemodialysis, compared with 6.9% using conventional dialysis. A rebound phenomenon after dialysis suggests that the total amount of drug removed may be less than initially reported. In any case, the efficiency of high-flux procedures in removing vancomycin is greater than that of conventional dialysis. Therefore, plasma levels should be monitored carefully in these patients, and the necessity for post-dialysis replacement doses of around 500 mg, that is approximately 10 to 15 mg per kilogram, should be anticipated. MOH continues to be febrile despite her triple antimicrobial regimen. Caspofungin is started empirically for potential fungal infections. In addition, pentamidine is begun to cover pneumocystis jirovecii pneumonia. How should caspofungin be administered in patients such as MOH with renal dysfunction? Next we will look at hemodialysis of caspofungin. Caspofungin is an echinocandin antifungal agent that is slowly metabolized by hydrolysis and N-acetylation, with little being excreted unchanged in the urine. Caspofungin is not removed significantly by hemodialysis or continuous hemofiltration. No dosage adjustment is necessary in patients with renal failure or on renal replacement therapy. The maintenance dose needs to be reduced in the setting of moderate liver failure, however. My next question to you reads, what factors need to be considered when other antifungal agents are used in patients with kidney disease? Amphotericin B is a poly-NA antifungal agent that has activity against a wide variety of fungi. Amphotericin B is extensively distributed into the peripheral tissue, and has a long elimination half-life of approximately 15 days. There is no significant change in the disposition of amphotericin B in patients with liver or kidney disease. The utility of amphotericin B has been limited due to its nephrotoxicity. Lipid-based formulations are associated with a lower incidence of nephrotoxicity and other systemic side effects. Triazole antifungal agents, e.g., fluconazole, posaconazole, voriconazole, or an echinocandin class, e.g., anadulafungin, caspofungin, micafungin, are alternative choices that are not potentially nephrotoxic, nor do they need to be dose adjusted in the setting of renal dysfunction, with the exception of fluconazole. The oral as opposed to the IV formulation of voriconazole and posaconazole should be used in the setting of renal dysfunction or for patients with a creatinine clearance of less than 50 ml per minute to prevent accumulation of sulfobutyl ether beta-cyclodextrin, the solvent vehicle found in the IV formulation. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 350.